Almost 70% of Americans take at least one prescription medication, and more than 40% of older Americans take 5 or more medications. Dealing with these systemic medications is an important issue that often leaves dentists unsure. So Dr. Resnik has done the research, and he will present to us how to modify our implant treatment to deal with the patient's systemic medications. Once again, Dr. Resnik will take this complex topic and break it down in a way that's accessible for all of us. Dr. Resnik, I see your slides. I hear your voice. Are you ready to roll?
So if we look at patients who come in our practice, 15 to 25% of these patients have significant systemic diseases and they're on multiple medications. Next slide. If we look at studies, this is a Wall Street Journal study that looked at patients over the age of 60 years old. Over 40% were on 5 or more medications, prescription medications. 18% had either 10 or more prescription medications. Next slide. 67% had greater than 5 medications, prescription and over-the-counter medications. Next slide. So we know one thing, that we have a lot of patients coming into our practices asking for dental implants with a lot of systemic diseases and with a lot of medications that have interactions and complications with some of the procedures that we do. Next slide, please. So if we look at some of the classification of medications, there's a lot of medications out there that with simple procedures such as a socket graft or an implant or maybe more invasive like a bone grafting, there are associated complications with those type of procedures. The question is, should these medications be modified prior to implant treatment? So what I'm going to do today is to go through all of these different classification of medications, ones that have direct effects on implant procedures that we do. Next slide. The first category is anticoagulants. And we can look at this quantitatively. Next slide. And also qualitatively. If we look at it quantitatively, it inhibits the clotting factors, and these are the drugs such as acuminin or the new novel oral anticoagulants that have just become very popular. On the other hand, there are qualitative ones that actually inhibits or alters the platelet function, and those are the most common being aspirin and also Plavix. Next. So if we look at Coumadin, next. Coumadin is a very popular drug for many, many years. It's a vitamin K antagonist. It's been used over the years for MIs, post-MIs, AFib, unstable angina, but most commonly now it is used for prosthetic heart valves. Next. If we look at Coumadin, it's always difficult to tell if the patient is going to be controlled or not. So what we like to do is usually to get what is called an INR test, an international normalized ratio. And that is usually good to get 24 to 48 hours prior to the surgery. And next, our therapeutic level is going to be between 2 and 3. So with that being said, the question is, should Coumadin, if our patient's on it, be discontinued? Next. So let's look at the studies. What do the studies show? Well, if you look at it, temporary discontinuing Coumadin, the problem with that is a lot of physicians don't like to do it because the patient can have an embolic situation where they could have a stroke or some type of cardiovascular issue. On the other hand, if you don't discontinue it, there's a school of thought that says that there is going to be excessive bleeding, and that could be problematic. So in this study, it showed never discontinue because embolic or stroke issues are far greater than bleeding episodes. Next. Here's another study. This is a ADA study, and it showed 3 times more likely if the anticoagulant is interrupted that you can have a stroke episode. Next. Here's another ADA that shows that routine discontinuation of Coumadin may place patients at unnecessary risk. And basically what they're saying is for many years, it has been commonplace for physicians and dentists to discontinue this, but in most cases, it is not needed. Next. So what is the end result? What do we take back to our practice? Number one, you always want to make sure the INR is in that therapeutic range between 2 and 3. Ideally, it should be 1, but when they're on anticoagulants, it should be 2 and 3. And modification is usually not recommended. How do we manage it? Number one, we want to get an MD written consult. We want to determine usually 1 to 2 days prior what the INR status is. If it is greater than 3, then we have the MD modify that patient's Coumadin levels so that we get them into that therapeutic range. If it's less than 3, then regular hemostatic agents can be used to control this. Next. Now, Coumadin has been around for a long time. However, physicians have come up with a better medication, and these are termed novel oral anticoagulants. Next. Now, what they have been used for is basically to take over for patients that are most commonly on Coumadin for AFib. So these patients we're getting more and more of these patients on these novel anticoagulants. Okay, I'm back online. So can we share this? I think it'll just be a little bit easier. So let's talk about these novel anticoagulants. So these novel anticoagulants, most common being Pradaxa and Xarelto. Eliquis is another newer one. These actually work by inhibiting thrombin directly or by inhibiting factor 10. Now, what is so good about these agents?
Not good.
You get the echo because you might be logged in on another device.
Okay. What is so advantageous about these medications is over Coumadin, there's no testing. So Coumadin patients have to get testing all the time. There is no diet issues where a diet what the patient eats may affect the Coumadin levels. These are fixed levels. So what ends up happening is the patients who are on novel anticoagulants take fixed doses, and there are shorter half-lives. So the question is, should we discontinue these, or should these be discontinued? What does the literature state? Well, the literature states that here's a good systemic literature review that from the oral maxillofacial surgery journals that shows there's very poor scientific data, really no general consensus on it. So discontinuation of this, no one really knows. If we look at up to date is what physicians use to get them basically up to date on the latest medications and what to do. So what their recommendation is preoperatively 2 to 3 days before, these should be discontinued. Postoperatively, it should be restarted as soon as possible. And that is when hemostasis can be obtained. So the bottom line is right now we're in the early stages of this, but most physicians will take them off 2 to 3 days before, and then they'll want it started ASAP. The negative of these novel oral anticoagulants is there's no reversal agent, or there is a reversal agent, but it's extremely expensive. Most ERs don't even have it yet. With Coumadin, it's very easy. If a patient's bleeding, they're given vitamin K or plasma, and that decreases the bleeding. With Xarelto and Pradaxa, there isn't a reversal agent. Now, luckily, the half-life is usually between 12 and 17 hours. It's not up to 60 hours like Coumadin, so it's not usually that big of an issue. So there's no test for it, so you can't do an INR on any of these medications. However, like I said, they are usually modified by the physician 2 to 3 days before, and then hemostasis within 24 hours. So how do you manage this? Always get written consent. The MD always will remove and continue the medication, let them quarterback it. And then you want to decrease the extent of your surgery. So you don't want to be doing an upper and a lower at the same time. You want to just be doing one area or one quadrant. And then you have to make sure that you have good hemostatic controls. So that is the Coumadin, the novel oral anticoagulants. Let's talk about the antiplatelets. So antiplatelets, there is no INR test. So it's not that easy. You would either have to take a bleeding time or a platelet count to see how well this patient is going to clot off. And there's a lot of patients on aspirin. A lot of patients just go on it themselves without even their physicians on it. So the question is, should aspirin be discontinued? Well, if we look at the medical journals are pretty straightforward on this. You never want to take a patient off of 81 aspirin. There's a higher rate of death, MIs, when you discontinue this. And it's really not that much of an issue with bleeding, is what most of their studies have shown. If we look at the dental journals, and here's just 4 right off the bat, almost 100% of these shows that you should never alter or interrupt aspirin 81 milligrams. So if, in conclusion, modification is not recommended, what do? You just want to decrease the extent or duration of the surgery and use good hemostatic control when doing surgery on these type of patients. Now that is 81 milligram aspirin. Let's look at 325. Now 325 is the regular dose, and not too many people are on this. However, some cardiologists really believe in, they like to have patients on a higher dose. So these patients are walking around with extreme platelet dysfunction here. So you have to be very, very careful. Prior to doing surgery on this, I call it case specific, because you have to look at the individual patient. This is where they should have a bleeding time and a platelet count. The physician should look at that. And again, decrease the extent or duration of the surgery and use good hemostatic control with the 325. Now, there also are antiplatelets that work a little bit differently, or different protocols, I should say. Aspirin is almost a given in most of these. And then the most common dual antiplatelet protocol is with Plavix. And Plavix, why do they do it? Because on some of these patients, especially that have stents, they cannot afford to have a clot on these patients. So these work on different mechanisms. So aspirin and Plavix work differently. So when they're combined, they have a very, very good mechanism to prevent clots. However, that does pose us a problem. So if we look at probably the biggest study that has been done in medicine on this is a 70,000 patient study on these dual antiplatelets. And what it has shown, mortality is decreased by 10%, strokes by 18%, and MIs by 31%. However, if you look at there we go. Okay, if you look at hemorrhage, Their percent was only 0.12% of these patients actually had increased hemorrhage. There were no fatalities, but it was just increased bleeding. So what that tells us is that these patients should be kept on it. And should the dual antiplatelet be discontinued? Most physicians will not do it, and rightly so. So modification is not usually recommended. You should always consult the physician and, again, decrease the extent and duration of the surgery and use good hemostatic control for these patients. Now, this is a very difficult, and there's a lot of information on this. I actually have charts in the textbook on each one of these anticoagulants, and it talks about dosing and interruption, what you can actually give to physicians. So a lot of physicians might not even be educated on some of these later studies. So you can send this to them. I have some of our doctors send this actual chart to the physicians a lot, just so that everyone's on the same page. So for anticoagulants, what is the summary? Number one, you want to minimize invasiveness of the surgery, break up the surgeries into multiple sessions, minimize duration. You want to get in and get out. That ends with less morbidity. Good, clean surgery technique, use hemostatic agents, and good suturing. So make sure that patient has good closure, primary closure, when you end the surgery. So that's anticoagulants. Yes.
Can I ask you, interrupt with a quick question here? I had a question about herbal medications that some patients may be taking. Are there herbal medications that can create some bleeding issues?
Yes, a lot. And in about 10 minutes, I'm going to get to that. I have a whole section on herbals, because that is definitely an issue, herbal supplements. I will get to that in a couple minutes. The second category is protein pump inhibitors. Almost 20 million patients are on it for heartburn, GERD, ulcers, etc. You wouldn't think that this would have any effect on dental implants, but it does. It impairs a lot of the bone remodeling and bone regeneration characteristics, or normal characteristics. So if we look at the studies, patients on these PPIs have decreased bone density. So what does that mean? When we put an implant in, it's like an osteoporotic patient, where we have less bone at the implant interface. That implant is more susceptible to complications. We have increased crestal bone loss. So post-operatively, force-related issues are even more important in these patients, because we know that this bone is not going to be as dense. It's going to be poorly mineralized. And with that being said, you're more susceptible to increased bone loss. And then if you're trying to build up bone, studies have shown that you have decreased bone metabolism and impaired healing. So when we try to grow new bone, these patients are more compromised. So PPIs do have effects on dental implants. And now if we look at the implant failure, there's multiple good studies out there, twice the amount of failures. Here's a second, 3 times the amount of failures. So something simple as these PPIs, you wouldn't believe that they do have effects on implants, but they do. So how do we manage it? It's a relative contraindication. There's so many patients on it, but it's your duty to inform these patients. And I'll talk to that at the very end about how to do that, but you need to advise the patient of the increased risks of complications from these, a lot of times, over-the-counter medications. A lot of patients now are on these selective serotonin reuptake inhibitors, SSRIs, mainly for depression. Why is that? Because depression is associated with low levels of serotonin. So these medications work great. They work probably the best out of all the different types of medications for depression. And they prevent the reuptake, or the inhibition of the reuptake of serotonin. If we look at the studies, what the combination of these drugs with dental implants: decreased bone density. Multiple studies have shown that. Increased bleeding. Also, there's many studies on post-op ecchymosis. These patients are going to bleed more. we're going to have to know that. So we have to have good hemostatic control. Also, they're going to bruise more. So we need to tell them that, they're going to be bruising for the next, or have bruising for the next couple of weeks. And then multiple studies on increased implant failure. So there is a direct correlation with SSRIs and dental implants. Again, it's a relative contraindication, and you should advise the patient on these possible complications as it can happen, and they should be aware of it. Now, Neil, to answer your question, herbal supplements. Herbal supplements is definitely a problem, and a significant problem. If you look at the herbal supplements, studies show about 25% of the herbal supplements out on the market right now have antiplatelet properties. And if you look at my career, I practiced for 32 years. I've only had to stop surgery once, and that was because of a bleeding episode, and it was from these herbal supplements. I found out afterwards the patient was on 25 different herbal supplements, and it's something that you just don't see. That's why it's very important that you ask the patient if they're on, and make sure that your medical history is updated with that. This is a mnemonic. It's called FUGs. And basically what it states is if the G with the herbal supplement is followed by a vowel, such as ginkgo or garlic, it's associated with adverse effects, most commonly bleeding. If it's followed by a consonant, then it's usually no adverse effects. So just a simple mnemonic like that can actually help you out a lot. 70% of patients taking herbal medications do not report their usage to their physician or their dentist. So make sure your medical history today, go back and see if you ask that question. If not, update your medical history, because that's rather significant, 70%. If you look at how we manage it, there's been multiple studies. I like this consensus. It's from the Orthopedic Surgery Academy and the American Society of Anesthesiologists. No herbal supplements 2 weeks prior to surgery. So a lot of these really do impair the platelet function, and you need these patients off at least 2 weeks prior to any surgery. And you should have that in your pre-op medications. Now, another category is osteoporotic medications, and there's a lot of controversy over this. So I'm going to go through basically what the latest literature is on this. Why are we worried about osteoporotic medications? Because there's a direct correlation, which the new term is called medication-related osteonecrosis of the jaw. You might have known it in the past as bisphosphonate-related. Now, because there's other medications, they broaden the scope of that, and it's MRONGA is the abbreviation. So when we look at that, there are two classifications of drugs that we worry about. One is bisphosphonates, which inhibit osteoblasts, and then these new monoclonal antibodies, which are being used for a lot of diseases. And these are lab fabricated antibodies, basically, that are injected in the patients. So if we further classify these, the bisphosphonates are into oral and IV, and the monoclonal bodies are in denosumab and biologics. So let's go through these one at a time. If we look at bisphosphonates, there are two different types, oral and IV. Now, many years ago, it was thought that both of these were bad and both of these were absolute contraindications, but that's not necessarily true. If we look at the oral uses, it's mainly for osteoporosis. The majority of the oral medications are used for oral. If we look at the most common, Fosamax, Actonel, and Beniva are the most common oral bisphosphonates, which a lot of postmenopausal women are on. If we look at the IV form, that is usually Zometa, which is about 10,000 times stronger than those oral medications. These are used for bone metastatic neoplasms, and also multiple myeloma patients. So these are heavy duty intravenous use of these medications. But let me differentiate these. Let's first look at what the studies show. So if we look at oral bisphosphonates, this is a great study that looked at, it's a systemic review meta-analysis. It looked at 256 actual studies, and they found no effect on implant success rate for oral bisphosphonates. So this is a really good study that's up to date. This is another study that looked at 724 articles and found, is there one protocol better than the other for these oral bisphosphonates? Not really. So there's no consensus in the literature on what we should do on these patients who have oral bisphosphonates. So what I like to do is go with what is in a lot of the organizations, AMIS, Dr. Robert Marks, who's an expert on this, and they've wrote many, many position papers on it. The first one was 2009, the second 2014, and they've had slight modifications since then. And the way that they differentiate it is if the patient is on an oral bisphosphonate for less than 3 years, you need to give good verbal and written informed consent, and then get an MD consultation. Possibly there might be a drug holiday, which I'll explain in a second, or possibly a CTX blood test. If the patient is on greater than 3 years, informed consent, MD consult, and they recommend a drug holiday. And there's different drug holidays, and I'll tell you the one that I recommend people follow, and also the possible CTX test. So why is this 3 years the pivot point on when you should do a drug holiday versus not? What has been found with these oral bisphosphonates are the half-life is greater and greater than what they thought. Now it's over 10 years. Some people think they accumulate in the body and they're infinitely there. So 3 years is kind of just a arbitrary time that they're saying this is when these patients are accumulating a lot of this bisphosphonate. So informed consent. This is, you need a special bisphosphonate informed consent. This is the one that I use. It's also in the textbook, which you can get. This goes over every aspect of bisphosphonates. The CTX test is a blood test, again, advocated by Dr. Marks. And what this does is this tells us the degree of osteoblast suppression, osteoclast suppression. And in this test, the higher number is actually worse. So, or I'm sorry, better. So you want a high number. When you have a lower number, that is where the patient is more susceptible to osteonecrosis. So Dr. Marks's threshold is 150. So if you do get one of these CTX tests, ideally it should be greater than 150 before you surgerize the patient. As for drug holidays, Dr. Marks has also written multiple papers on this. The most common drug holiday for an oral bisphosphonate is no bisphosphonate 9 months prior to your surgical procedure, and then 3 months post-operatively. And here are just two of Dr. Marks's papers that he has written on that subject. So now that I went over all this for the oral bisphosphonates, what is the recommendation? First of all, if it's early on your learning curve, this is your first implant case, you might want to just refer it. It might be easier than to deal with any possible complication, even though complications are extremely low. If you do decide to treat the patient, it's as a relative contraindication. You want to get good informed consent, MD consultation. Dosage duration is the point where they'll determine, is it better to do a drug holiday and or a CTX test. So a lot of these cases, I leave it up to the physician to actually come up with the final treatment plan. So that is with oral bisphosphonates. Let's talk about IV bisphosphonates. Most common one out there now is Zometa. And this, like I said before, has been implemented in a lot of the bad press on bisphosphonate osteonecrosis. And early on, this is actually where they found that there was a problem. Now, in dentistry, we always get thrown curveballs, and here's another curveball. So what physicians do now is for osteoporosis, they give an IV infusion of Zometa, which is under the trade name Reclast. And they give this once a year. So instead of patients taking all these oral bisphosphonates, they take Reclast once a year. So what does that do for us? Well, if you look in the literature, there's multiple cases. Here's one by Dr. John Suzuki, fracture implants after Reclast. Here's sinus lift on the left of your screen, and then implant failure on the right of your screen. So there are multiple cases out there with Reclast. So what I recommended for IV bisphosphonates, it's an absolute contraindication. Now, certainly some practitioners in our profession can handle these complications, so it might be a relative for them, but for doctors, just especially early on the learning curve, you do not want to be treating these types of patients. What I don't like about it is on the lower right hand of your screen is the package insert to Zometa or Reclast. And it basically says, avoid having any dental surgery while being treated with this. This comes from the FDA. The FDA puts this warning label in. So I'm looking more medical legally, even though the occurrence of this, prevalence is very low. I would just rather doctors who really can't or aren't used to treating these type of complications just stay away from these. And it would be a patient referral for these Zometa Reclast patients. Now, a couple more monoclonal antibodies. Denosumab comes as two different types. One is Prolia, and the second is Xgeva. Now, Prolia is a very common osteoporotic drug. It's given subcutaneous twice a year, really an easy drug, no side effects. Xgeva is used for metastatic cancer. It's also given subcutaneous, but double the dose, and you get it monthly. So it's a little bit of a concern. If you look at the studies, and on this, either Prolia or Xgeva, there's very little data. And there's a questionable correlation. Does it even cause medication-induced osteonecrosis? The good news about this is it has a very short half-life. Half-life is about 26 days. So it's in and out of the system, unlike the bisphosphonates. Now, this is, I've written multiple articles on this. So if you want more information, get the textbook, or you can Google it. The latest is the treatment option, which is a really good one, and I have not seen problems with this. It's called a delayed dosing window. But first, if we look at no treatment, there really is no literature to support that. No modification of Prolia. The problem with Prolia patients is if they go on it, and it's stopped or interrupted for a long period of time, these patients actually get spontaneous fractures. So physicians don't want to take them off of it at all. So they don't like the drug holiday. This delayed dosing window is a protocol out of Europe, and it uses the pharmacokinetics kinetics of the Prolia. And basically what it says is the surgery date should be at the 5th month, right before another Prolia injection, but within a 15-day window. So let me try to explain that. So if you look at the normal dosing of the top diagram I have for you at the top, it says every 6 months you're getting Prolia. What this delayed dosing protocol states is that because of the half-life, when you get to that 6th month or the 5th month, the chances of an osteonecrosis is very, very low. So they're recommending at that 5th month, within that first 15 days, you go ahead and do your elective implant procedure. Then what the physician does, instead of giving that next injection at the 6th month, they wait the 7th month. So what they're seeing is no problems with this protocol, because all they're doing is they're delaying it only 1 month. So they're not seeing the spontaneous fractures in the long bones of the body like they do on patients who basically they cut it off cold turkey. So Prolia, I would highly recommend using this delayed dosing protocol, and it's becoming more and more accepted. So Prolia is a relative contraindication. You might have to even inform the physician about this new delayed protocol. You can give them one of my articles on it, or pull one of those citations that I have there. Xgeva, these are metastatic cancer patients. I'm going to say it's an absolute contraindication because very high doses, and these patients really aren't the best candidates for that. Other osteoporotic drugs out there, Forteo is a drug that also is an injection. It's actually a parathyroid hormone. No association with osteonecrosis. In fact, it's used to treat osteonecrosis, so you don't have to worry about that. Avista is another one. It's an estrogen agonist. Don't worry about that one either. No association with osteonecrosis. Now, biologics. Biologics are a concern, and everyone should be wake up and listen to this part of this lecture, because these can have a high degree of morbidity and mortality. These drugs are a new classification of drugs, the most common being Humira and Enbrel. You might, if you watch golf, you'll see Phil Mickelson. He swears by Enbrel. This is why he's been able to continue playing golf. They're wonder drugs. The problem is they don't know how they work real well. This is a good article by Dr. Joe Silla from Allegheny General Hospital in Pittsburgh. And this was an implant osteonecrosis on a Humira case. And basically the patient had a large resection from patient being on Humira, which is an immunosuppressive drug, and the patient ended up with a real bad osteonecrosis. This is another example, one that I was involved with, an Enbrel case, where the patient actually ended up with a resection from this was from extractions on Enbrel. But the interesting thing, if you look at any of the package inserts on biologics, they talk about osteonecrosis, but it's not like a bisphosphonate. So they're in the infancy of this. I would put this back with the physician, get a consultation. It could be a relative, or it could be an absolute contraindication. Certainly, if you're early on your learning curve, you would want to refer this. Some physicians do like doing drug holidays on this, but before you would do any type of surgical procedure, you want to get a detailed, informed consent on any of these biologics. And the last category I'm going to go over is the immunosuppressants or the chemotherapeutics. And I just put a couple. I could talk about this for probably 4 hours. There's so many of them now. But why I picked these two is these type of drugs are being used off-label now. So if you look at methotrexate, that has been used as a chemotherapy agent for many, many years. Very common one. That's an absolute contraindication when the patient's undergoing chemotherapy, high doses of methotrexate, immunocompromised. You don't want to be doing any surgery. But now physicians are using them off-label, and they're using lower concentrations of these drugs. So probably the most common way to treat rheumatoid arthritis now is with methotrexate, but it's with a very low dose. Studies have shown no problems, no complications with these lower doses. So I want to use this as an example to let you know, you can have a drug that you might think is an absolute contraindication, but in reality, it may be used for an off-label use and a relative contraindication. Another drug is cyclosporine. People have heard of this for many years. It's for transplant rejection. Many, many studies out there showing real problems with bone. But if we look at it, if the patient just had an organ transplant, certainly you don't want to be doing surgery on them. That's an absolute contraindication. However, it's being used for something such as psoriasis. So cyclosporin is very low doses is used for an autoimmune disease disorders, and that would be a relative contraindication. So that just shows you the importance of getting medical consultations and evaluating this with the physician. The last drug I'm going to go over real fast is clindamycin. People use it all the time. People love it. However, this drug is getting more and more out of favor. This is a study from one of the implant journals that shows that if you use clindamycin as a prophylactic antibiotic, it increases the risk of post-sinus infections after sinus graft surgery. Other studies, this is from the orthopedic literature, reduces alkaline phosphatase. Alkaline phosphatase is needed for the mineralization of bone. It also decreases the calcification of bone. And then in the perio literature, clindamycin has been linked to resistant bacteria that causes peri-implantitis. So just something as simple as clindamycin does have some very negatives out there that you really have to look at. And so I know I went a little over time because of those computer problems, so I apologize for that. But what is our take-home message today? There's a lot of medications out there that can cause a lot of bad problems in something just very simple as a socket graft or a single implant or something rather invasive like a large bone graft. Our goal is to decrease complications. So as you know, I always end with something to take home with you. Number one, what do I see a lot in the medical legal arena? Doctors do not read the medical history. Read the medical history. If you see a medication there that you don't know what it is, find out what it is. Ask the patient. Find out the duration and the dosage. This is a free website. I would hope everyone downloads to their phone, Hippocrates.com. It's a great free app. It tells you about every drug, every disease. It gives you interactions, drug disease interactions. It identifies medications. It gives you guidelines. And like I said, you put it right on your cell phone and you put the drugs in, and it's becoming very, very popular in the healthcare industry. So it's called Hippocrates.com, and that's a free app. Rule number two, and I have defended multiple doctors who have not actually done this, but been accused of this. You never modify a drug prescribed by a physician. Now, you can say that you never do it, but patients sometimes assume that they should go off their Coumadin or whatever. So always inform the patient never to modify it. So it's one thing that you don't do it, but it's another thing you need to inform the patient. Never modify a medication that the physician put you on it unless the physician modifies it themselves. How do we do that? Number one, on your preoperative medical history form, make sure you write it here. Never alter any medication unless instructed by your physician. Why do you need it preoperatively? Because it might be too late if you do it on the post-op. But if you do this, they sign it. Now there's a paper trail to help save you. Secondly, post-operatively, always have it there because they might think, okay, they're bleeding more, they're going to stop their anticoagulants, and then they stroke out and there's a problem. Rule 4, always obtain medical clearance in writing. I prefer not to call the physician. Use my form here. If you want this form, Chairside Magazine, Glidewell can help you with that. In March, I wrote this article on evaluation of dental implant patients, and you can download my form. This form has been used in court. It's foolproof. It's very, very in detail. I even give you a cover letter to write to the physician so you know what to write. But what it does is you write to the physician what the patient put on their medical history form, what medications you intend to give them. Then what they do is they tell you if there's any other medical issues that you should know about, they sign off on the current medications you're going to use and any modifications that they give the patient. And then they give you the check off that they clear the patient for surgery. So use that form. It's a paper trail. If you want more about this, this is a very complex topic. I did it rather fast in 45 minutes, but you can get more of that in the latest edition of the Contemporary Implant Dentistry. So again, I apologize for the early computer programs and problems, and hopefully we have some questions there, Neil.